Our next presenter, Susan Phillip, who is the director of San Francisco's STD Prevention and Control Services Section and chair of California's STD Controllers Association. She's a graduate of Washington University School of Medicine and received her MPH from the Harvard School of Public Health. Her training also includes an internal medicine residency at the University of Chicago and a fellowship in adult infectious diseases at the University of California, San Francisco. Dr. Phillip will provide an update on gonorrhea resistance as well as information on select STDs.
So here's an outline. We'll talk about what we can offer you, what you can do to help with prevention efforts and gonorrhea treatment. And just as a reminder, for the full treatment guidelines, you all are going to hear extensively about syphilis. We're going to talk about gonorrhea because those things, questions come up all the time, and gonorrhea things have changed. But here's where you can get sort of the full treatment guidelines. And I think you all have gotten access to our clinical protocols as well, which we're happy to provide to everyone. But the guidelines came out in 2010. They come out about every 4 years, and they were revised just this year around gonorrhea specifically. So we'll talk about that. But here's where you can go to get that from the CDC website. Okay, so I stole this from UPS, right? What can Brown do for you? But what can we do for you? Because as Kyle said, we are a service organization. We are seeing fewer and fewer percentages of the reportable STDs at city clinics. So it's no longer true that city clinic sees, most of the syphilis, most of the gonorrhea, most of the chlamydia, and that's fantastic. I'm so happy by that, because what that means is that screening is happening, and the message to screen is going out into the community, and providers in San Francisco are doing the work that is going to be decreasing STDs and improving sexual health. So it is really, really great that that's happening. But what that means is that then there needs to be partnership, and we need to work with you and through you to accomplish the work of our mission, which is to improve and maximize sexual and reproductive health in San Francisco. City Clinic, many of you know, it's the only municipal STD clinic in the city, and that's really unusual for a major metropolitan city. Most cities have several of them scattered around. Incredibly busy place, busier than the size and the capacity that we have for it, 19,000 patient visits last year. 75% of the people that come to City Clinic are men, 35% overall are MSM, and we're really an important clinical training and research site. So we have a lot of ongoing research work. You're going to hear about some of that related to HIV prevention when Stephanie Cohen speaks later today, but also related to STD clinical trials of new testing devices, new treatments, and so it's a really important facet of the work that we do in San Francisco. And then for clinician consultations, you're able to call and speak to a clinician about your questions and even sort of talk with us and refer patients over. So we're happy to help in that clinical capacity as well. And as the quiz at the beginning said, last year was our 100th year anniversary, and I think it really speaks to the commitment that San Francisco has to maintaining sexual health. One of the key things is our website, and as Kyle said, we try to keep that updated and keep information there in kind of a place where providers are able to access it when they need to and get what they need. But something that's really useful, we think, is the monthly STD report. We have a real commitment, and Kyle's team has really been at the forefront in making sure that our data turns very rapidly, and that every month we put out a report about STDs in San Francisco. And I will say that, my favorite thing I think that for providers to really watch is not just the numbers, but there's always an editorial at the bottom that highlights something that is new or different or that we want you to be aware of. And so you can get added to the email list. You can also get it off of the website. So if you want, you can go ahead and email me. My email's at the end of the presentation. Or you can go to the website to get more information about that if you want to be added. And so those are some of the things that we provide in terms of training and updates and clinical consultation and services. But what is it that you can do to help us? Because we do want it to be sort of a two-way street. And I'm going to talk throughout my talk, kind of going to relate it to gonorrhea about some of these pieces. But the things that you're doing already are a huge help. So screening appropriately for STDs, the way that Kyle described, including chlamydia and gonorrhea, using NAT testing in women who are less than 26, and then chlamydia and gonorrhea screening using NATs at the pharynx and the rectum in MSM, getting syphilis testing and HIV testing. HIV testing every 6 months is what was recommended for STDs. We say every 3 to 6 months. And then treating STDs according to treatment guidelines is another really big way in which you all can be of tremendous help in decreasing the STD burden, and I will talk about that in relation to gonorrhea. reporting to us, including gender of sex partners and treatment. So by the California Code of Regulations, it's mandatory that both labs and providers report to us, and that is coordinated through Amira's team in the screening program. And I know it seems like a pain, and it seems like the labs are going to tell us about cases of gonorrhea, chlamydia, but they don't tell us treatment, which is incredibly important, and they don't tell us gender of sex partners. So all the data that Kyle was showing you about how we can sort of monitor and decide how to do prevention efforts with specific groups, we wouldn't be able to do that if we didn't have the data from you all. So it's incredibly important, and we appreciate your work to do that. And then when it's appropriate, if you can encourage patients with STDs and HIV to work with us. So it's really great that you're all here, because you are all ambassadors of the work that we do. And our staff may need to interview your patients with syphilis, potentially your patients with resistant gonorrhea when that becomes more prevalent in San Francisco, and with HIV. And we're doing that to not only impact the health of the individual patient, but also the population. So it becomes very important. So here are the CMRs that you're all familiar with, and we talked a bit about this, but a key thing is that looking at this information, we really do use it. And you see it back in the monthly reports, and we use it to help develop and determine the prevention needs in San Francisco. So trust me when I say that it doesn't just go into a box in the basement at City Clinic. We are really using that data, and so we really appreciate your help in getting it. Syphilis patient interviews we talked a bit about in partner services. It's offered to all patients with a new early syphilis diagnosis. So this is either primary syphilis, secondary syphilis, or early syphilis, which is within 1 year of diagnosis. Culturally and voluntary services. So no one is forced to talk to our staff, but we really would like to encourage it, and we want it to be the norm in San Francisco to work with us to try to find partners. It helps us understand where prevention efforts are needed. And this is really what's most important. For syphilis, it allows us to contact the partners who may have been exposed and offer them preventive treatment so they themselves do not develop a chancre or a rash of secondary syphilis and become infectious to others. And this is really a key role that providers and the health department play together along with patients. So please, have your patients work with us, encourage them to. If you have further questions about what exactly is involved, please feel free to contact me or Stephanie or Charles Fan. Any of us would be happy to talk with you about what it means to work with syphilis patients. And then I want to talk, we have a really great partnership as well with HIV prevention in DPH. And there's a joint program called LINKS, Linkage, Integration, Navigation, and Comprehensive Services. And so these are the services that are provided to folks who are HIV infected. So there are 3 components of this. One is people who test positive for HIV, helping ensure that they get linked to care. Partner services, again, offering to contact the partners of patients who are newly diagnosed with HIV in order to bring those folks in for testing, because we find an incredibly high rate of positivity among the partners of folks who are newly diagnosed, as you can imagine. And we really want to find those folks to get them into care and get them into treatment for their own health and, again, for the health of the community. And navigation services. So if there are patients who have been in care but are not fully engaged and who have been lost to care, what we would like to do in the department is actually help bring those folks and bring them back to care so they can be retained. Because again, we know that this is serving dual purposes. One is for the health of that person, but secondly, it's for the health of San Francisco in reducing the overall amount of community viral load that could exist here. And that way decreasing the risk of new infections to other folks. So I think there's a links flyer that is in the back, and you can get more information there about this program. So let's move on to gonorrhea, a very exciting topic. So 1937 here on this timeline, and then 2007, there should be a plus there because it goes beyond that. And here's just the different antibiotics over time that have been used for gonorrhea. So in the very beginning, sulfa drugs were effective, and the straight lines on these are where they stopped being effective and the resistance developed. And it used to be that penicillin was an effective treatment. So World War II, you'd see these advertisements. It says buy bonds on this mailbox, and underneath it says penicillin cures gonorrhea in 4 hours. So you're seeing your doctor, and it helps you defeat the Axis powers by getting treated. It really, truly, there were a lot of ads around this, and some of these old ads, were highlighted last year in our 100-year anniversary campaign out at City Clinic. Really fascinating. But penicillin doses, what this expanding shape represents is that the doses had to get higher and higher. And eventually there was the emergence in the 1970s of penicillinates producing Neisseria gonorrhea, which eventually became completely resistant to penicillin at all. Tetracyclines, like including doxycycline, were effective for a period of time, and then resistance developed there. Recently, you all may remember that fluoroquinolones such as Cipro were very effective oral treatment, and what we found is that in San Francisco and in California, resistance was sort of identified much earlier than the rest of the country, and in MSM, resistance was identified much earlier. So in California, we stopped recommending Cipro long before the rest of the country. We did that in 2002, 2003, and by 2007, CDC said, no one anywhere should be using Cipro or other fluoroquinolones for gonorrhea. So what does that leave us? Well, we're here now. The third generation cephalosporins are the recommended class, the mainstay of our treatment for gonorrhea. But what we're seeing is that there should be maybe a question mark here, and I'm going to show you some of that data. We're now increasingly worried that this sort of last remaining class of reliable antibiotics against gonorrhea is being lost again to increasing potential resistance and decreasing susceptibility to this antibiotic. Spectinomycin is still listed here because it is potentially effective, but we can't get it in the U.S., so it is a little bit of a moot point. So can we learn anything from history and how the spread of resistance has happened in the past? So red is sort of the pattern that we saw globally around penicillinase producing Neisseria gonorrhea, so when the organism became resistant to penicillin. And here in green is sort of the spread of another class of antibiotics, ciprofloxacin and the fluoroquinolones. And you see it's sort of remarkably similar. So the first case reports of resistance usually identified in Pacific countries, Japan, Southeast Asia. And then they move from there, so to Europe, to Australia, and they move across the Pacific Rim countries. So in the U.S., Hawaii is usually the first state to identify resistant organisms or decrease susceptibility. And then here we are on the West Coast. So we're really working very closely with the Public Health Lab and Dr. Piandori, as well as looking at City Clinic to really identify this early, because we know that we are going to be, along with Hawaii, kind of the canary in the coal mine around this. And so that's why providers, we want you all to have a heightened sense of awareness, and we want to talk about this today. So how do we know where this is spreading and how this is happening? Well, there's worldwide systems that have been set up to look at surveillance for changes in the antimicrobial susceptibility of Neisseria gonorrhea. But the main one in the United States is something called GISP, or the Gonococcal Isolate Surveillance Project. And this is the sentinel surveillance for the United States. And it looks for trends in the antibiotic susceptibility of gonorrhea isolates. So it happens in 26 to 29 STD clinic sites around the country. And what happens is that symptomatic men who come in with urethral discharge, the first 25 to 30 of them have a specimen taken for culture and looking for gonorrhea. 4 to 5 regional laboratories then do the susceptibility testing. They're sent to CDC for confirmation. And what they're looking for is something called the minimum inhibitory concentration. So I know my lab colleagues will cringe, but my very simplistic way of thinking about this as a clinician is that you put increasing amounts of antibiotic in the plate with the organism, and then where it stops growing. So the minimum concentration of antibiotic that inhibits the growth. So as that number creeps up, that means that the bacteria is increasingly able to live in the presence of antibiotic. So we're looking at changes in this over time, which may eventually result in clinical treatment failures and resistance. But what we're actually measuring is what's the susceptibility and how's it changing. So City Clinic has been a GISP site since its start in 1987. And there are other sites in California as well, but we are the one for San Francisco. So we get the urethral cultures from the first 25 symptomatic men, and we send them to our public health lab, and they send them to Seattle, that is our regional lab, and also to CDC. And we do some additional work with those as well in conjunction with Dr. Pandori and his team. The limitations are that, it's an STD clinic population. This is not a generalizable population. And these are only urethral cultures. When Kyle was just talking with you about how there's so much more positivity in the throat and the rectum for gonorrhea than there is urine. And previously, we've had problems with getting the results back quickly, but that's greatly improved. And again, as we said, we're doing some enhanced work around this, particularly looking at some molecular epidemiology methods, and we're trying to also do some interviews and follow up on cases that may have some decreased susceptibility. So as a result of this GISP data, there's been a lot of concern and attention around gonorrhea recently, and some of you may have even seen the New Yorker had an article about gonorrhea very recently, and it's a really well-written and great article, and really points to the importance of pharyngeal infection as maybe a cause of some of this. But here was an editorial that came out in the New England Journal of Medicine earlier this year, and Gail Bolin, who used to be the director in San Francisco and then was the director of the California STD program and now is the director at CDC of STD, really was writing about this emerging threat of untreatable gonorrhea. And when they look, this is from the GISP data, when they look over time at the percentage who have elevated MICs to cefixime, so cefixime is an oral third generation cephalosporin, what they really see is that it differs by region, so the highest likelihood of having that finding of increased MICs were in the West, and the highest were in men who have sex with men. So if we think about in San Francisco, we're kind of the nexus of MSM and in the West. So we are likely to see the emergence of this before others. And so that's why it's really great that providers should really be aware. So your role as key STD prevention partners and tying it into STDs are to screen appropriately, and particularly thinking about the pharynx and the rectum in MSM. Use those gnats because they really do help with detecting disease there. And you do have to do screening. So these are, again, reflecting data that were published in 2005, but when we look at the data more recently, it really is very similar. And this is what Kyle was alluding to, is that urethral infections, asymptomatic here is light green, symptomatic is red. And let's just look at gonorrhea here for a minute, because it's very striking. So if you look at urethral infections, 90% of them were symptomatic. So someone is going to have symptoms and present. There's only 10% that's asymptomatic. Now, if you look at the rectum, it's almost flipped, right? It's like 16% will be symptomatic, but 84% are asymptomatic. So that means if you don't screen at that site, you're not going to detect that infection and be able to treat it. And here again is really looking at, what if you only screen the urine? Why wouldn't it pick up the other infections? And it really is not the case. And again, reinforcing what Kyle has already said. Identified infections in green, missed infections in orange. If you just screen the urine in men, what would happen is that you'd identify 14% and miss 86%. Now, if you just screen the throat and the rectum, what would happen is that you would identify over 90% and you would miss only 8.6%. So this is, again, some of the data that support our recommendation to really focus on the rectum and the pharynx for screening. Okay, treatment. According to CDC and SFDPH treatment guidelines, remember I said that these were revised just in August. So here are the recommended. This is the only now recommended treatment for gonorrhea. So ceftriaxone plus azithromycin or doxy. And remember, this is dual treatment. So we need to start thinking about gonorrhea the way we think about TB and the way we think about HIV, that we need to use multiple classes of drugs against it. So even if you have a test result that says gonorrhea positive, chlamydia negative, go ahead and add the azithromycin or the doxy, even if you know that patient is negative for chlamydia. You're not treating chlamydia with this additional treatment. You are double covering for gonorrhea. So what are the alternatives? Now remember, cefixime as an oral third-generation cephalosporin plus azithro or doxy used to be recommended. The big shift in August is it just got shifted down to alternative. So they really are emphasizing using the ceftriaxone-based regimens now. So you can have this as an alternative for uncomplicated urogenital GC, or if they're cephalosporin allergic, azithromycin 2 grams orally once. But this should be used with extreme prejudice because this is this is a drug to which the organism has developed resistance, and high-level resistance has been reported in the U.S. and Hawaii. So we do not want to use this routinely by any means. And now this, again, is a recommendation that CDC has made, is that if you're using anything other than ceftriaxone plus azithromycin, you should be bringing the patient back for a test of cure with NAT at 7 days. These data are based sort of mostly on one study, and we're really trying to work with CDC to get better data around it. But regardless, this is what they've put out to date. So this is what we have as providers. So the recommendation is, based on the fact that dual treatment may hinder development of resistance, that's the goal. We don't think we're going to be able to prevent it, but we can hold it at bay as long as we can. And there's no longer different recommendations for urethral and rectal versus pharyngeal. So in that way, it makes it easier. Remember, the pharyngeal infections always needed the ceftriaxone-based treatment. But now you can just, not have to worry about that distinction. Just treat everyone with ceftriaxone. And treatment with azithro is a dual treatment, as we said. So here we have FAQs that have been updated, and those are available on the website. In California, providers can legally prescribe treatment for the partners of their patients with both chlamydia and gonorrhea. Since 2001, we've been able to do it for chlamydia, and gonorrhea since 2007. So it's a little more recent, but it is very well established that there is legal protection. You are authorized under the law to do that. You don't have to see the patient's partner in order to prescribe. At City Clinic, what we do is we give out partner packs to people, which includes the medication plus instruction sheets, including warnings about allergy. And we also will tell them, particularly if they have gonorrhea, that they should come in for treatment. So again, partner packs, people have wondered about that. What we include in the partner pack is cefixime, the oral third-generation cephalosporin, plus azithromycin 1 gram orally. So we are still recommending this in San Francisco as a harm reduction measure. We know that not all partners are going to be able to or willing to present to a clinic, but we are strongly encouraging them to come in for ceftriaxone-based treatment because we do acknowledge that that is the best treatment. And the wording of our handouts now say that. They really do encourage people to come in. And again, it is legal to treat patients and their partners for gonorrhea and chlamydia without a face-to-face visit. So these are, again, information that is available and resources that you can get from our website. So here's our patient-delivered partner therapy. This one happens to be for chlamydia, but we have the gonorrhea sheets as well, and they're available in Spanish also. And you can alter this to sort of be for your own site as well. So please check those out, cityclinic.org. You can click on for providers and find those there. And people often ask me, what's been the adverse events? Like, have you ever gotten a lawsuit or gotten in trouble because a partner pack caused somebody to have a severe allergic reaction? That has not happened anywhere in the state of California since this became legal for chlamydia. And there's been a lot of scrutiny around it. So I think given the correct information sheets, which you're required to have, and allergy warnings, it's a very safe and effective a way of getting the medication to partners. Okay, and the last things that you can do, we did really already talk about, but reporting them, including gender of sex partners in treatment, and encouraging people to work with us. And the real issue is going to be around if there are cases of suspected resistant gonorrhea, and we really are going to have to interview folks to learn more about the epidemiology, where they've met their partners, where we might be able to find their partners for testing them. And this is not something that people are used to around gonorrhea. So again, sort of having the shared voice and kind of common discussion from both their clinical provider and the health department is very useful and will be useful for this. So what happens if you suspect treatment failure? Well, just remember that you should just really make sure that you rule out re-exposure, because many of our patients at City Clinic, that certainly is a possibility, and not all their partners get effectively treated, or they have sex with them before the 7-day period that we encourage people to wait. You can call us at STD to discuss if there's a question at all about possible treatment failure, and we're happy to talk with you, Stephanie or I, or the clinician line during clinic hours. Have them come back for repeat NAT testing from all sites if that happens, urine, rectum, and pharynx. Consider getting a culture specimen. Please talk with us and we can help coordinate with the lab, maybe even get you some of the culture media that we might need. Because remember the GISP and the antimicrobial susceptibility we were talking about? Right now, the best way, the gold standard for doing that is using culture. And because we are encouraging the use of NAT, it's just a better test for clinical diagnosis. Our culture capacity in the clinical sites is limited. So we need to balance that. We need to, if you have a question of treatment failure, we want to try to get you some culture media so you can take the specimen with the patient. So that's all I have, but again, I want to say again, all of us are very committed to being a resource for you all, so please feel free to email me, and you can get the materials at the website, and I really want to thank you for your attention, it's great to see so many people here today, so thank you.